Hi, my name is Audrey Housman. I am a family nurse practitioner and currently a DNP student at Maryville University. Today, I will give you a brief overview of my DNP project, Reducing No-Show Rates in a Federally Qualified Health Center. Frequently missed appointments, or no-shows, are an ongoing issue in healthcare. A no-show occurs when the patient fails to cancel or reschedule their appointment prior to the appointment time. Missed appointments impact multiple aspects of care and health outcomes. They can cause delay in diagnosis and treatment of an illness, minimize appointment access for other patients, and negatively affect healthcare revenue. A literature review was done to find effective interventions to reduce no-show rates. The literature review provided excellent groundwork for the DNP project. In the approximately 20-plus research studies reviewed, the intervention that proved to be the most effective in reducing no-show rates was the addition of a personalized phone call reminder prior to the scheduled appointment. Personalized phone calls from the staff have been studied and have shown a reduction in the number of no-shows. In a study by Mohammed et al. In 2016, calling patients to remind them of their appointment and offering to reschedule the appointment if they're unable to attend reduced no-show rates from 49 to 25% in just 4 months. Other studies showed that reminder phone calls increased the number of cancellations and appointments rescheduled, which allowed patients that needed to be seen to be able to come into the clinic on the same day, and providers had more availability. The purpose of this project was to decrease no-show rates by using personalized phone calls after a missed appointment. The purpose of the phone call after the missed appointment was to identify barriers to patient care and help provide any resources available so patients were able to attend their appointments in the future. These phone calls and barriers were tracked using tracking sheets developed by the researcher. There are many benefits to reducing no-show rates for both patients and staff. When patients come to their appointments, they receive preventative care, have a better chance of early diagnosis and treatment of diseases, and consistent health care for management of chronic illnesses, which help result in better patient outcomes. Appointment availability for other patients needing appointments increases when patients cancel or reschedule their appointments instead of no-showing. Provider and staff productivity also improve when appointment attendance improves. Overall, the clinic runs more efficiently, and there is a decrease in negative outcomes and negative effects on revenue organization-wide. The goal of this project was to reduce no-show rates and provide health care that is quality and consistent, and most importantly, improves healthcare outcomes for patients. The PICO question developed for the project was as follows. In patients who frequently miss appointments in primary care, what is the effect of personalized reminder calls on improving no-show rates compared to automatic phone call reminders within 2 months of implementation? Community Health Care, otherwise known as CHC, is a federally qualified health center. There are currently 6 medical clinics and approximately 50 providers that provide care to close to 40,000 patients at these locations. These providers manage both acute and chronic illnesses and provide preventative care. The intervention was implemented at 1 of 6 clinics in the organization. Nationwide, 91% of community healthcare patients are at the federal poverty level, and in Iowa, 93% of CHC patients are at the federal poverty level. One study done by Mohammadi et al. In 2016 found that poverty and unemployment were associated with a higher number of appointments being missed by patients. The average no-show rate at CHC was approximately 16 to 30%. No-show rates are monitored weekly by the scheduling coordinator and reported as a percentage monthly for all providers in the organization. These providers care for the most vulnerable population in our community. Unmet needs and barriers to care, such as lack of transportation, were a consistent theme in literature associated with missed appointments. Fiore et al. In 2020 said that lack of transportation and patients insured by Medicaid have also been found to have a higher rate of no-shows. Many patients at CHC experience barriers to health care. They struggle with poverty, addiction, and mental health issues. Depending on their situation, the doctor's appointment might not be a priority for them that day. There is not currently a no-show policy at CHC. However, there is an automatic reminder system that sends out a text message or a phone call reminder 72 hours and 24 hours prior to the scheduled appointment. However, this system often malfunctions, so patients do not always receive the call and the text message. In the past, a sit-and-wait approach was tried. If a patient missed multiple appointments in a row, they would be placed on a sit-and-wait list. This meant that those patients were unable to schedule an appointment in the future, but rather would have to come and sit and wait until they were seen on the day that they wanted to be seen. This was very ineffective and did not help improve no-show rates. The research, data, and concern for patients' well-being is what prompted the intervention for this project. Participants in the project included myself as the research facilitator, along with the clinic support staff and nurses who helped to make the personalized phone calls and collect the data. I worked closely with the scheduling coordinator who collects and monitors no-show rates. The guiding coalition for this project included the chief medical officer, the CHC clinic manager, the clinic nurse, and myself. Members were selected on their commitment to the proposed change, as well as their position, expertise, credibility, and leadership. The study included all patients with a scheduled appointment during the intervention period. Parents or guardians were contacted for individuals under the age of 18. Tracking sheets were developed to document phone calls made and to identify reasons as to why patients missed their appointments. Tracking sheets that were properly filled out were also included in the study. Pre-intervention no-show data was collected between March 1st and April 30th of 2022. The intervention of personalized phone call reminders before and after an appointment were implemented between May 1st and June 30th of 2022. If tracking sheets were not filled out completely, that information was excluded from the project. Patients that were scheduled as fill-ins or same-day acute appointments were also to be excluded because they did not receive the intervention of a personalized phone call prior to the scheduled appointment. The project timeline was as follows. The project was developed between May and July of 2021. During this time, the purpose, vision, and staff education sessions was provided to the guiding coalition. During the months of July and August of 2021, Chapter 1 was written, which included the interest, expertise, purpose and aims, type and inquiry, background, significance, support for project, and the benefit of the project. During the months of October and December of 2021, Chapter 2 was written, which included search history, integrating literature review and critique, concepts and definitions, and the theoretical framework. Between January and May 2022, the Institutional Review Board application was written along with Chapter 3, which discussed the methodology, design, data collection, and analysis plan for the project. In April of 2022, tracking sheets were edited so they could better collect data for the project. The intervention was implemented between May and June of 2022. This data was collected and a retrospective review was completed in July of 2022. Data analysis was completed between July and October of 2022, along with the completion of Chapter 4, which discussed the methods of evaluation, data analysis, and presentation of the results. Chapter 5 was then completed between October and December of 2022, which further discussed results and limitations of the project. This project was a retrospective evaluation of a quality improvement project. Personalized phone calls prior to the scheduled appointment and after a missed appointment were implemented over a 2-month intervention period. All data collected was anonymous and no patient consent was required. Pre- and post-intervention no-show rates were collected and reviewed to determine if the intervention showed a significant decrease in no-show rates. The second part of the study was to identify and document reasons why patients were unable to attend their appointments. There was an issue with identifying barriers. There were several attempts made by designated staff to contact patients after a missed appointment, but this was unsuccessful due to unanswered phone calls, phones out of service, and voicemails not being set up. This arm of the project was discontinued due to a lack of response from the patients. Data was collected using a secured Excel spreadsheet along with 2 different tracking sheets that were developed. The Excel spreadsheet tracked the pre- and post-intervention no-show rates. Monthly data collection of no-show rates at CHC is a current practice. This information is available to all providers. One of the tracking sheets tracked the number of patients' phone calls made prior to the appointment. This helps staff keep track of the number of patients called, the number of voicemails left, and the number of patients who were unable to be reached. The second tracking sheet was for tracking patients who missed appointments and barriers that were reported. Staff could also note whether or not patients chose to reschedule an in-office appointment or a telemedicine appointment. These barriers were being tracked for future implications for the organization. Data collection involved a retrospective review of pre- and post-intervention data. All patients at CHC Family Practice Clinic with a scheduled appointment in the 2-month intervention period were included in the study unless exclusion criteria were met. No-show rates were collected and reviewed before and after the intervention was implemented. 2 different tracking sheets were used to collect the information. This included the number of patients who were contacted, and all information collected was anonymous throughout the study. Here are the 2 tracking sheets that were used. Appendix A has the scheduler spreadsheet, so this is where staff was to record the missed appointment and any barriers to the appointments, and whether or not the patient scheduled on telemedicine or in office. Appendix B is a post-intervention tracking sheet, which helped staff track the number of patients called, number of voicemails left, and number of patients that they were unable to contact during the intervention. Data was analyzed with the help of Dr. Pauls, a statistician at Maryville University. The total number of patients called and the total number of patients who missed an appointment were both collected. The data collected was nominal data. The chi-square was used to determine the difference between the pre- and post-intervention data. The minimal suggested sample size was 154 patients. Outcomes of the retrospective quality improvement project failed to show a statistically significant difference between pre- and post-intervention data. The pre-intervention no-show rate was calculated at 19%, with 81 out of 427 patients missing their appointment. The post-intervention no-show rate was calculated at 17%, meaning 65 out of 507 patients missed their appointment. This was only a 2% decrease in no-show rates. During the retrospective review, an error in methodology was identified. Both the pre- and post-intervention no-show rates included same-day acute appointments, where no phone call reminders were made. Because of this, no-show rates are tracked. Because of the way that the no-show rates are tracked at CHC, it's difficult to separate the same-day appointment information from the chronic appointments that were scheduled. There were a few limitations to the study. These could have affected the validity and reliability of the results and the outcomes. An error in methodology was discovered during the data analysis, as discussed previously. Both pre- and post-intervention no-show rates provided to the researcher included acute or same-day appointments. This data was not precise and included patients who received the intervention and patients who did not receive the intervention. In addition, the 2-month intervention time interval was considered minimal, resulting in a small sample size, suggesting a longer intervention period is needed to determine the effectiveness of the intervention. Another limitation was a failure to contact patients after a missed appointment. As mentioned before, many of these patients struggle with mental illness, substance abuse, and poverty. Patients at times can be very uncooperative and unreliable. Staff was unable to document barriers to the appointments because they were unable to reach the majority of patients who missed an appointment. Because of this, this part of the study was eliminated. The results of the study presented many implications for future practice and research. The purpose of the study was to reduce no-show rates and address barriers to missed appointments. This quality improvement study did not result in a significant reduction in no-show rates, and identifying barriers was proven unsuccessful. One recommendation is to increase exposure to the social services that the clinic provides to patients. Social workers, care coordinators, and caseworkers could play an important role in reducing no-show rates through home visits with patients who repeatedly miss appointments. They can help to identify barriers causing them to miss appointments and provide support and resources as appropriate. Another implication could be that health education focusing on importance of attending appointments, healthcare needs, and outcomes would be provided to patients. If patients better understand the consequences of a missed appointment, they may be more likely to attend their appointments. Working on a more reliable, automated phone call and text messaging system should also be a goal of the organization. This can help provide reliable reminders to patients. Updating patient contact information with each visit and asking patients if they experience any barriers to attending their appointment may also be helpful so staff can provide resources when available. A final implication could be to take the findings of the study, address the limitations, and initiate future research studies to determine best practices for reducing no-show rates. In conclusion, the purpose of the study was to reduce no-show rates at Community Healthcare, a federally qualified health center family practice clinic. Personalized phone calls were implemented by designated staff prior to a scheduled appointment and after a missed appointment. The hope was that reminder phone calls would significantly reduce the number of no-shows that patients had, and staff would be able to better determine barriers to patient care so that we could provide resources to eliminate these barriers. The study unfortunately resulted in no significant difference between pre- and post-intervention no-show rates, and the staff was unable to get a hold of patients after a missed appointment. Further research is needed to determine the effectiveness of this intervention and to help develop other interventions that focus on reducing no-show rates and improving patient outcomes. Community Healthcare will be using this information for future studies to help reduce the barriers and no-show rates for our vulnerable patient population. I want to thank everybody for your time today in listening to my presentation, and feel free to reach out if you have any questions about any of my study or the results, or if you have any suggestions for future implications for this to help reduce no-show rates. Here are my references that were used in this presentation. Many of them had a lot of the same support for reducing no-show rates with personalized phone call reminders, so I felt it was very helpful. Again, thank you for your time, and please reach out with any questions.